everyone, Ryan Rubino here. Today I'm going to talk about provider attribution, which is something I just think is really interesting. And part of the reason I think it's interesting is because it sounds simple and easy at face value, and there's just so much more complexity to it than I think a lot of folks realize. Perhaps some of you already kind of dealt with this firsthand within your organization and maybe appreciate that a little bit more. But for those of you that haven't, I think it's the type of capability that can sometimes be overlooked or an afterthought or kind of an add-on. And if you don't figure this out properly, a substantial amount of your analytics might just not work properly. To ground the conversation, it's important to think about what questions are we trying to answer here? And at the highest level, we're trying to understand how is a provider performing? And kind of the next cut down from that is how are we attributing patient outcomes or performance to a provider? And there's just kind of nuance at every step along the way as we talk about this. But when we're talking about patient performance, we're not necessarily talking about the patient, we're talking about person performance and how do we attribute perfect person performance to provider. So meaning you might have multiple patient or member records that are all associated with the same person. So you got to run that data through an MPI, just another step and another wrinkle. Another question is, how are we kind of defining provider and how are we grouping providers? So is the provider an individual doctor, or is it practice, or is it region, or some other grouping of providers? So also think another data source, that how are we actually defining that organizational hierarchy? And then from there, what metrics are we looking to calculate, and can we actually roll those up properly? So, and in value-based care, there's a ton of stuff that's associated. Quality metrics, cost and utilization metrics, risk adjustment, patient registries, kind of you name it, all of those things we want to measure and evaluate and roll up at the provider level. So I think the flip side of what that means too is that if you can't do this well, nearly everything that you're trying to evaluate, you might not be able to do very well if you can't appropriately attribute it to a single provider or a group of providers or practice, something to that effect. And then lastly, what business objectives are we working to achieve? And the answer here is not singular. So are we trying to understand how a plan or a payer might be calculating bonus payments for a particular provider? Or are we trying to just understand how did we perform last week? And the answers to each of those questions are very different from a provider attribution standpoint and what you want to be displayed in the reports, dashboards, and analytics that you have available. So what provider attribution methodologies are important as you're trying to understand and evaluate your performance? And for a lot of people, this starts with who's defined as the PCP in an EHR. So, kind of who is that clinically defined provider? Now, some wrinkles associated with this is if you have a clinically integrated network, you might have multiple different EHR systems. You have patients that are moving around, you have providers that are moving around. You might have conflicting information. You might not have one singular PCP defined. So how do you deal with that? We'll get back to that later. But that's kind of looking at who's responsible for this patient and how are they performing. The next view you might want to look at, again, from that provider standpoint, how did I perform last week? Did I complete those tasks and close those gaps that I was responsible for? But whether or not I'm the assigned PCP. So, this is looking at the rendering provider, and it could be really anybody that saw that patient, and are they completing those activities that are expected of them? So then a somewhat different perspective, kind of similar to that clinical PCP, but who is the plan or the payer assigning and defining as the PCP? So this is data that's coming from the plan. Plan says X provider is responsible for this particular patient or member. And one of the things that I think is very interesting about this particular methodology is that you can have a patient assigned to a provider, and that patient may have never been seen by that provider, may have never been seen by that health system, meaning the patient doesn't even have a patient record in the EHR. So if you were to pull up a list of, hey, who do I, what gaps do I need to close? That patient might not even surface in that list because it's based on a different data source. And this is plan assignment. This is how the plan is measuring your performance and how they're potentially going to calculate bonus payments at the end of the year based on how well you did with those patients. So understanding that there's conflicting assignments across these different categories, there are other ways that we might want to attribute a patient to a provider to just help understand who is the actual provider, and is it based on who's responsible for the majority of the costs for that patient, what provider actually saw the patient the most, or then for Arcadia, a commonly used attribution method is a functional provider. And this is basically a logical compilation of all of these different methods. If there's a clear PCP, you define that person. If there's not, then you do this, then you do this, and you do this. There's kind of a default configuration, and then we often will tweak and customize it based on certain organizational specifics. So really, again, it comes back to that business case. What are you trying to achieve? And I think that all of these are potentially important. And can you quickly and easily toggle back and forth in any of your reports or analytics to see a different view based upon what you're trying to achieve? So if that wasn't enough complexity for you, there are other wrinkles that we didn't even talk about. These assignments change over time. So how do you deal with updating those regularly and having a process in place for that? How do you deal with historical reporting? The provider organizational structure also changes over time. So kind of the similar set of wrinkles right there. And I think the main takeaway here is this is just one of many different nuanced sets of capabilities that are necessary for value-based care analytics. And I would, if you're looking to try to do this on your own, I would definitely encourage you to look hard at some of these details and determine if you'd be better off trying to work with an organization like Arcadia, that we've already solved many of these and we know how to stitch all of the different pieces together to make this stuff work.